Okay, so it's 12 o'clock and we'll make a start. Welcome to this East Genomics Medicine Service Alliance, or EGMSA Nursing and Midwifery webinar. Thank you for joining us today. Just a few bits of housekeeping. We'll just ask delegates to turn your cameras and microphones off. Please put questions in the chat and we will come to them probably at the end, because we've got quite a packed schedule. We are recording the session, and as your names don't show, we assume this will be okay, but please let us know if that isn't the case. And we will share the slides with you after the event, and it will also go onto our YouTube channel. Okay, so next slide, please, Ian. Okay, so why are we here today? To speak to you about this and what do we want you to get out of it. We've put some learning outcomes here and hope that by the end of the webinar you will have knowledge of the work of the GMSA and how we are working with clinical nurse specialists. We hope you will have increased your knowledge of how pharmacogenomics supports personalised medicine, to have gained insight into the role of genetic counselling and how we work with genetic counsellors to support patient pathways. And then finally, to understand how genomics is being used in diabetes care. And we'll hear from Anita about the autonomous role of the diabetic genetic nurse. So we thought it would be helpful to just sort of hear from people on the call about where you are now in terms of your knowledge and understanding of genomics. So we've put this QR code on here for the Mentimeter. So I just asked that if you could scan the code. There's 2 questions, and then that will give us sort of some insight into your confidence really of genomics at this time. Okay, now if you don't have the QR code scanner, you can go on to the website menti.com.
Just pop that in the chat for everyone there. So
thanks, Ian.
Just switching to the website now.
Okay. Okay, so the first question is genomic testing used in your patient pathway? And it looks like more of the group are, so it's changed to about 50-50. So it looks like it is being used in the patient pathway as far as we know for half of the group on the call today. Okay, and then the next question, please, Ian. And this was to find out how confident you are in your understanding of how genomics can support patient pathways. Okay. Okay, so that's helpful to know, and I think well, you know, we certainly hope that by the end of this webinar we will have helped to increase your knowledge and start to build confidence through providing you with that knowledge and insight into the work that we're doing. That's really helpful, thank you. Okay,
Get back to the presentation.
Yeah, so we're going to do this by obviously the presentation, beginning with myself, and then we're going to go over to Paul Selby, the lead pharmacist for the GMSA, for the East GMSA, and then we'll hear from our genetic counselling colleagues, Mairead and Izzy, and then, as I say, to Anita. Okay, so next slide, please. So my name is Vicky Carr. I'm the lead nurse for the East GMSA. I'm based at Adam Brooks in Cambridge, and I've been in post since January of this year. I'm going to begin my talk with a bit of background and context into why we're doing this work, and then how we're working with clinical nurse specialist teams and the next steps. So next slide, please, Ian. So I thought we'd start with an NHS England definition of genomics. So whereas genetics is the study of our genes and the way that certain traits or conditions are passed from one generation to another, genomics describes the study of all the person's genes, or the genome. But what's important here is what we're doing with this information. to advance patient pathways. Okay, and what's driving this work that we're doing? So it was the NHS long-term plan in 2019 that set out really ambitious targets, as you can see here, for the UK to become the world's most advanced genomic healthcare system, education and training a key component. There's the 2020 strategy paper, Genome UK, which has a 10-year vision, and wants the NHS to be the first national healthcare system to offer whole genome sequencing as part of routine care. And I've just put some examples here from children's services, what this actually means in practice. So comprehensive and precise diagnosis, more personalised treatment, and then hopefully that will reduce the use of harmful medications and interventions, and even lifelong health problems that can be caused by the treatment that we use. So you can really see the benefits of people of genomic testing being integrated into healthcare systems. Okay, next slide, please. The role of NHS England is to enable the NHS to harness the power of genomic medicine and improve the health of the population as part of the NHS long-term plan. So the East GMSA, we are commissioned by NHSE to deliver these targets. Nursing and midwifery is one part of this, and a big challenge for us is developing our understanding of the nursing and midwifery role in a field that we haven't typically been in up to now. Okay, next slide, please. The strategy paper that I mentioned a couple of slides ago has 5 key aims, but also a really high number of overall objectives. But these high priority areas are the faster diagnosis and treatment of cancer, as it says here, whole genome sequencing for rare disease and cancer, data diversity, that we've got a really strong focus on improving equality, diversity and inclusion in all of the work that we're doing, so that the changes we're making can benefit everyone. And then points 4 and 5 here are much longer term projects, much broader across the whole of England, but our future health and data sharing, and really looking at research there. Okay, next slide, please. So a massive part of implementing this change is through workforce education. Health Education England are working towards Genome UK's commitment by ensuring that all healthcare professionals, including nurses and midwives, have awareness and knowledge of genomics relevant to their role. And a bit later on, I'll be sharing a link to the Genomics education programme, where you can access bite-sized modules. And why are we prioritising nurses and midwives? Well, we are at the largest section of the workforce, so the thinking is that we're well placed to optimise the contribution of genomics. It's in our nursing and midwifery professional standards from 2018. And actually many nurses and midwives are already involved in genomics in specialist areas. But we might not call it genomics, interestingly. We might be calling it molecular testing or something different. Okay, next slide. So this is the geography of the GMSA. There are 7 GMSAs across England, shown here on the map. So it transcends usual NHS boundaries in that we cover the east of England and the East Midlands, and the idea is that we work collaboratively across our region, but also with the other lead nurses and midwives across each of the 7 GMSAs. And we're commissioned, as I've already said, by NHS England and held to account by them for the work streams that we are responsible for. It's just another slide showing the 29 trusts that are part of our geography, 16 acute trusts, 4 principal partners: Addenbrooke's, Norfolk and Norwich, Leicester and Nottingham, and then the other acute trusts, mental health and community, who we're all sort of linking with to make contacts and hopefully improve equity of access to care. Just a quick slide showing you us. This is our team. There's Melissa, our associate nurse, Annette, myself and Katie, our programme manager. And our nursing midwifery transformation projects for this financial year are 4 cancer pathways: lung, colorectal, breast and ovarian, 2 rare disease, cystic renal disease and familial epilepsy, and 1 feto-maternal. And what we've been doing is developing our understanding of the touch points where CNSs connect with patients, and how genomics is included now and how it could do in the future, and what is needed to get from where we are now to where we can be. So I wanted to use an example of the lung cancer pathway that the Northwest GMSA started their work with in April of this year. And the purpose was to explore the lung cancer CNS knowledge by information gathering on key patient touch points. We did this by distributing questionnaires to all lung CNS teams in our GMSA, and each GMSA did the same thing to hear how services work and utilise genomic testing. They were then invited to 4 workshops to contribute and share, really come together as a national working party. And the early themes that came out, which won't surprise you, I'm sure, that everyone's service is set up differently. The scope of CNSs is very varied, but commonly everybody needed more education and the confidence in genomics knowledge was variable. And then they go on to develop something called G-Notes, which I'm going to tell you a bit more about on the next slide. So G-Notes is something that the CNS teams that we are engaging are involved in developing, and it's an idea that if you're faced with a patient in clinic and there's some genomic conversation to be had, we recognise this might not be part of your daily work yet, but you're going to need resources to support you in that conversation. So there's the in the clinic section known as tier 1, which you would go into and it would run through with you what the testing options are. And then latterly there's a knowledge hub for you to go back to and extend your learning with an encyclopedia of resources. And we're involving CNSs in developing the G-Notes for each of these different patient pathways. So how you can get involved, the education, there's a wealth of resources out there, and I've shared the link underneath that first point for how you can access those. You can also contact me if you'd like more information about education. We have the Links network where we meet with each of the 29 trusts across the GMSA bi-monthly, and you could find out who your local person is, about local activity. I would invite you to consider how genomics is currently being used in your patient pathways and whether there's scope to develop this. This is our first of what I expect to be many webinars, but we'd like to know from you what you would like to hear about in the future. And then I wanted to share with you about a conference that we are running in November, which is free, and it's on the next slide. We're running a conference for clinical nurse specialists and nursing leaders, holding it in Leicester, and we will share in the chat the link for how you can sign up to that. We'd be very happy to have you there. Okay, so I'm going to hand over to Paul now, and I will let you introduce yourself in a bit more depth, Paul.
Thank you. It looks like we're doing the next slide, please. Set of work. Yeah, perfect. So, yeah, my name is Paul Selby. I'm the lead pharmacist for the East GMSA, and therefore East Genomics by association. And I know some of you from working at Addenbrooke's Hospital for many years. So it's really nice to see such a good turnout from both CUH and from NNUH. And essentially, one of the sort of the core areas that I'm asked to focus on is personalised medicine, and that incorporates a couple of things, but it does include pharmacogenomics, which I'm hopefully going to touch on mostly here, but also things like polygenic risk scores, which would maybe be a topic for another time. So these are the objectives that I'm hoping that you'll achieve by the end of the session. So if we can go on to the next slide, again, another definition for you all, but really just highlighting that pharmacogenomics is about how an individual's body responds to medicines, okay, and it's using that genetic data to guide that. So next slide. And the other thing I wanted to unpick was around personalised or precision medicine. So these terms get used a lot and they're largely interchangeable. They're sort of not one definition of one or the other, but it's really thinking about how we use medicine and how we use that personalised for individuals. So you can see there genetics, environment and lifestyle are all important. But also there's a model which looks at the 4 Ps. So prediction and prevention of disease, better diagnosis or precise diagnosis, personalised and targeted interventions, which is really sort of the area that I'm thinking about here, and then more participatory role for patients. So that really means engagement in designing the services and designing their own care and making sure that their views are taken into account. And you can see that sort of funny little vignette, which just sort of highlights in traditional medicine, or in the way that we practice medicine in this country, we have traditionally given everyone the same dose, seen how they respond, and then adjust things. And personalised medicine will offer us that opportunity to say, well, this patient is different from that patient, so we'll use different treatments or we'll use a different dose. And so we're sort of starting to build that information. So it can be very, very powerful. Next slide, please. And this is just a infographic, which I think is always helpful to think about. On the left-hand side, when we use treatments and medicines in particular, we can get variable results depending on the patient, and there's not always a way to predict it, but you can sort of group patients into whether some people have effect, some people don't have effect, and by understanding what underlies this, we can start to move from a situation where we give everyone the same dose and dose adjust to identifying everyone as an individual and then tailoring the drug and tailoring the treatment to them. And we know, and we would expect additional studies to show, that you get improved long-term benefits. You would get sort of more targeted treatment, so better outcomes, but you'd also get reduced side effects when you're considering how they would metabolize the drug and how the body processes it. So it all comes under pharmacogenomics. It's 2-part and has, yeah, as I said before, could be really potential in how we can use it. Next slide, please. Lovely. So coming back a couple of steps and just thinking about really what do we do in the UK in terms of where is genomics established, and we've obviously got a specialist here, so a lot of you or half of you sort of felt that you were using it and you had sort of variable confidence, and half of you aren't really using it. So largely it's been historically used to supporting genetic diagnosis and to identify patients at risk of diseases, and in particular if we think about things like cancer and BRCA2 mutations, and therefore either enhanced screening or taking a intervention forward. If we have a genetic diagnosis, we can identify specific treatment for patients, and then that improves quality of life. So actually we've been using genomics in this respect for many years, but not on large scale. It's been focused down to sort of the diagnosis aspects and that way. And then within pharmacy, we have 2 key sort of concepts, two principles that we really look at. And these are medicines optimization and medicine safety. And again, we can think about medicines optimization as being targeting the treatment to the patients, picking the right option first, picking the right dosing and getting better outcomes. And then we can look at medication safety as pharmacology guided as one of in there. So basically, how is the drug metabolized? What is the variation? And therefore reducing side effects. Now, we've only got a short period of time here, so identifying lots and lots of examples is not going to be possible. And actually, I reckon a lot of you in your own practice will be able to identify things. But 2 of the areas, or 2 of the treatments I wanted to focus on in terms of Specific or targeted treatment would be patients with cystic fibrosis, and in those patients, depending on the specific variation that they have in their CFTR gene, would dictate which treatments we would give them. To look at it from sort of medication safety, we've been doing a lot of work with an enzyme called dihydropyrimidine dehydrogenase, and the gene that codes for that is called DPYD. For patients who are undergoing chemotherapy with fluorouracil or capecitabine, we would run this genetic test to identify whether they're likely to have a low metabolizer status, which means they're at increased risk of toxicity from this chemotherapy. So again, reducing side effects and should be without any detriment to sort of patient outcomes in terms of efficacy. So again, really nice, clear examples of how we can use those two principles. Next slide, please. And so there have been studies, there is evidence going on, and you can see from this slide just that we've got some really good evidence starting to build. And in particular, I think it's really interesting that when they've looked at this in primary care, that the use of genomics improves prescribing and for patients. And so it's been shown that it can work. It's just about how we deliver that as a GMSA. Next slide. So brief pause. How many of you are using pharmacogenomics already, and do we incorporate personalised medicine? I'm always keen to get a bit of feedback and interest from people that I'm presenting to rather than you just get talked to. So we'd really appreciate your thoughts, and we'll just spend a couple of minutes just to see if there's anything that comes out of that. Yes, Anglia?
Yes, hi. So I'm a clinical nurse specialist in neuro-oncology. So we predominantly deal with brain tumours, and we use genomics quite a lot with sort of the whole molecular profiling. We have done for quite some time in regards to finding out for the malignant gliomas and the primary brain tumours, which has helped guide treatments in terms of chemotherapy options. But what we're more and more doing now, which is kind of my interest in all this, is we're beginning to look at METs. So we're doing the whole genome profiling predominantly within a clinical trial. But I'm just wondering, earlier in the talk, there was mention that the lung CNSs had been sort of given this questionnaire to fill out. And I'm just wondering if at the moment we seem to be working in two separate silos, that the brain, we're looking at genomics and at analysing the data from the brain tumours, and it looks like similar streams are happening from their primary sort of lung disease. And is there any scope to sort of marry the two up at some stage?
I would think so. So we would probably target that down the route of the oncology and pathology working group, I think. But obviously, yes, I mean, there's certainly some work being done, which I'm not a part of, but I know is happening around circulating tumour DNA. And we have tumour site. So we have treatments for cancers based on the tumour profile rather than the site of the tumour as well. So we've got those coming through. So I think it's definitely something that will hopefully be brought together and is a really interesting area.
I do find it quite fascinating. So I think the trial that we've had shows all these targetable mutations that we're picking up on an individual basis, as you say, and at the moment it's just trial data, but it's fascinating. Thank you.
Yeah, no problem.
Paul, we've got just 5 minutes left. There's a comment from Rachel Fenn in the chat about, for you to have a look at.
So yes, so there's a mention about Herceptin and receptor status of tumours for breast cancer targets hormone therapy. So Herceptin's lovely because it was the first drug that came out that really targeted a mutation in cancer. So for us, it's a really good example. And I am of an age where I can remember that we used to have to wait for our patients to call in before we would even make Herceptin. It was so expensive and so new. So lots of change there. In the interest of time, I'm going to head on, but thank you very much for those comments. So just to think about how we can use genomics in other ways and how these are already being used. So we've talked a little bit about cancer, so I won't comment on that. What I thought I might just highlight is that there are other ways we use genomics in terms of COVID, all of the sequencing and the sort of the variations that have been highlighted from that. interesting, but we also can look at tuberculosis, so we can look and identify variants that would be drug resistance, but we can also diagnose other bloodborne viruses such as hepatitis C. We can use genotype and then change treatment on there. These are some of the areas that I would argue we're using pharmacogenomics in practice already. And again, it will depend on your specialities, but a lot of you will either know these cases or you won't at all. And you can see that, again, a lot of them are sort of specific and specialist used drugs. So we're not doing very well, or we're not using pharmacogenomics more broadly. And if you look at the right-hand side, the slightly lighter section, you can see some of these things around statins, and there's interest in prescribing antidepressants. So potentially some change. Next slide. And yeah, I just wanted to highlight a couple of things you might need to pop one on. I'm not sure if it's missing something yet. So these are the examples around cystic fibrosis, and I've got a for EGFR TK positive mutations in non-small cell lung cancer. So you can see here that we're getting better outcomes, and you know, the treatments for CF are really interesting because they're improving quality of life as well as improving symptoms. Next slide. And then to look at that in terms of the pharmacology guided or treatments. So I mentioned, so there's two other examples that would be interesting, I think. So we can test for CYP2C19 variation and use that to manage antiplatelet drugs in MI. And we've also got this example of TPMT and thiopurines. So we know we can do this and get good reactions. And you can see in particular with TPMT, tenfold reduction in hematological reactions. So neutropenias is a really big difference. And so actually it's a significant part of care for patients starting on thiopurines. Next slide, please. So good. That brings us to the end. So we should be in time now, Vicky, for more questions and comments on those. So shame to rush past those examples. But I think it gives people time to think about things, and really it's about what's going to come into your own practice, I think, which is key.
Yeah, that's great. Thank you, Paul. And then if anybody does have any questions, please put them in the chat and we will do our best to come to them at the end. Okay. Okay, thank you. So next I'm going to hand over to Mairead and Izzy. Okay.
Great, thanks, Vicky. Can you hear me okay?
Yes, I can hear you.
Perfect. So we're myself and Mairead are both genetic counsellors in the team at Addenbrooke's, and so we thought we'd give a bit of a talk about sort of what genetic counselling and genomic counselling is and sort of where we sit in that pathway, just to give a bit of context to it, really, because there's a lot of talk about genomics and it's a new thing for a lot of areas, but not so new for us. So next slide, please, Ian. So as I say, genetic counselling isn't new, so it's new to sort of mainstream, and sort of a big conversation is now happening about it sort of nationwide and internationally as well. But actually genetic counselling as a sort of term and a profession has been known about since about 1947 and has been an established profession since the late 1960s. And genetic counselling is sort of the process of helping people understand and adapt to medical and psychological implications of genetic conditions and the familial implications as well. So with the nature of genetics and genetic testing, it doesn't just impact that person sat in front of you. And we like to think we're sort of the people side of genetic testing. Yeah, next slide, thanks, Ian. And so what is genetic counselling today? So it's an autonomous profession in its own right. Yeah, you can click through those two bits, thank you. It's a protected title now as well, which is great. And there are a couple of ways of getting into genetic counselling. So there's a master's programme through the University of Glasgow and Cardiff, also a sort of direct scientist training route as well, which combines sort of the clinical work with the academic training as well. Next slide, please. So where do we work? So we work in regional genetic services. So we're in most sort of big teaching hospitals, and then we usually cover that area, which I'll show you a map of in a moment as well. We work really closely with our clinical geneticist colleagues, so our consultant geneticists and registrars, and clinical scientists as well that are working in the labs doing the genetic analysis, the report writing. We work as non-genetics multidisciplinary teams as well, so we'll often sit in different MDTs, or people will come to our MDT meetings, and that is obviously just growing with mainstreaming as well. And there are also genetic counsellors that do work in the mainstream setting. So there are genetic counsellors based in oncology or breast teams, for example, or in cardiac teams. And we work closely with mainstream clinicians to sort of help with the delivery of sort of mainstream genomic testing. Next slide, please. So this is the map I said I'd show you. So this is showing that it's a hub and spoke model really for how genetic services work in the UK, and this is the same for the other genetic services around the UK as well. So we're based in Cambridge and Addenbrooke's Hospital, but we cover the whole of East Anglia, and we hold peripheral clinics in these locations as well. So a lot of you today, I think, are from some of these different locations. So we do work closely with clinicians, not just at Addenbrooke's, but with all of the hospitals in these locations too, and come at least once a month, if not more, to hold clinics in those hospitals too. Next slide, please. So the sort of demonstrates that hub and spoke model. What services do we offer? So we carry out diagnostic testing where we're looking for the genetic cause of somebody's diagnosis or presentation or family history. We also do predictive testing, which is where the gene alteration is known in the family, and we're offering testing to an asymptomatic or unaffected person to see if they have inherited that genetic condition and are at risk of developing the associated symptoms, and then help them to put sort of appropriate management in place if so. We don't always offer genetic testing, it's not always indicated, so sometimes we're providing risk assessments and screening advice, and we help with sort of ongoing appropriate surveillance, managing and supporting families and our patients and their families with whatever that genetic condition is and whatever management they need. As I said, we're closely linked with our clinical scientist colleagues as well, which work within the East Genomic Laboratory Hub. So they're based just along the corridor from us, and so a lot of the lab testing is done through them, but it is also sort of spread out amongst the region with these genomic laboratory hubs now as well. And so the clinical services are our main work, but we don't just do the clinical service for our patients, we also do a lot of education. And so I'm one of the training and education leads in the team. We provide obviously training for our own trainees and students and placement students, our registrars in the team, but also to other healthcare professionals. So we see that as one of our really important jobs, particularly with mainstreaming, is to make sure people do feel confident in other specialties and in mainstream specialties, and making sure they feel confident to offer genetic testing and offer the right information and advice to their patients, but also know where to come to if they don't know or if they need some support. Importantly, what we don't do paternity testing. We don't test everyone for every genetic condition. It has to be appropriate, and I do touch on, or Mairead will touch on, the genomic test directory in a bit as well. And we usually avoid predictive testing in children unless there are childhood implications of that particular condition. So if it's something that is adult onset, then to protect that child's autonomy and their right to know or not to know, that sort of testing is offered after the age of 18. Next slide, please. So there's a lot of us as well, and we've got a few different organisations, but there's about 7,000 genetic counsellors around the world now. So a lot of people haven't heard of us, but we're there. Next slide, please. And so just a little bit about what genetic counselling is as well. It requires good balance. So if you click through about four clicks or so, Ian, thank you. So we're delivering information to patients and families, telling them about the genetic condition, the inheritance. We're educating them so that they understand what they're being tested for and whether they want to go ahead with that test and how they'll cope and manage with that. We're also providing, really importantly, that emotional support both before, during and after test results or testing. And we help and aid with family communication. We don't just leave someone with a result and say, right, you've got to go and tell your family that. And we can help with that as well. So lots of different aspects to our role. And I'm just going to show sort of where we sit. I'm trying to think where you were taking over, Mairead. Is it a little bit further? So just where we sit in the patient pathway as well, and sort of how things come to us. So we receive referrals from, it could be primary or secondary care, and that gets triaged to work out whether, firstly, perhaps we don't need to see that patient, perhaps we need more information, it's not appropriate, or we might accept that referral. Next slide, please, Ian. And so if we do accept a referral, then we'll decide what's the best management for that patient. Do we speak to them by phone? Do we arrange a clinic appointment? Are we just sending a device by letter? If we do get to a clinic appointment, next slide, please, Ian. This is the sort of thing that happens in that appointment. So we are very fortunate. We have between 45 and 60 minutes with our patients, which we know is a very lucky position to be in, but we'll address their major questions or concerns, take a family and personal medical history. We'll go through the genetics that's specific to why they're being seen. So give them a bit of background about genes so that there's a bit of context to that, talk about what we're offering them and any associated risks and inheritance, the practicalities of the actual genetic testing, and a plan for results and testing of family members. Next slide, please. And there's also the psychosocial concerns, which I've touched on. I don't want to rush through these, but I'm conscious of time. So essentially the crux of it is we want to make sure somebody is ready and supported to have genetic testing. We don't just want to offer them a test if they're not in the right place to receive that. It can be a big piece of news that doesn't just affect them, but affects the family as well. Next slide, please. So there's a few bits probably to click through. But yeah, a lot can come up, a lot of different emotions in a genetics appointment, such as guilt, fear, shame. People can experience lots of different types of loss as well. And we also are always conscious to refer onwards if people need more support. We can probably skip this one. This is just to say about risk. So there are lots of different ways of people interpreting risk. So that's an important part of our sort of consideration as well of when we're giving information to people. I think this is where I'm handing to Mairead.
Thanks, Izzy. So an important part of our role is obviously deciding what genetic testing to offer to who as well, and that has been kind of streamlined by NHS England when they produced the National Genomic Test Directory a couple of years ago, and this document lays out all the different tests that we can offer and also the eligibility criteria for each of those tests as well. Next slide, please. On the test directory, it also mentions which specialities can order specific tests. So more and more genetic testing can be offered in the mainstream setting, as Izzy mentioned. And some examples of that in our region is cystic fibrosis carrier testing is often done through the GP, unless a couple is currently pregnant. Genetic testing for epithelial ovarian cancer or hereditary breast cancer can be done through oncology services, and testing for neurological conditions can be done through neurology services as well. So the idea being that these mainstream clinicians consent patients and order the testing. If a pathogenic variant is identified in the test, then they can be referred on to clinical genetics for a more in-depth discussion and advice. Also, if patients need more psychosocial support, they can be referred on to us before initiating testing as well.
5 minutes, Mairead.
Okay, thanks. Next slide. Yeah, so this is just a rundown of the different tissues we test. It's usually blood samples, but also during pregnancy, we can do cell-free fetal DNA, CVS, chronic villus sampling, or amniocentesis. If a lady miscarries, sometimes we test products of conception, and specialised services where they offer genetic testing before implantation of embryos as well, like we refer to guys usually here. And sometimes tumour samples can be used for testing. So for example, immunohistochemistry staining for Lynch syndrome. Next slide, please. So when we order the test, our lab colleagues obviously perform it, and the results are returned to the ordering clinician. So that's either genetic counsellor or the consultant, or if our mainstreaming colleagues are ordering the test, that's who the results will get delivered to, and they are responsible then for feeding back that result to the patient and referring on to us if a variant is identified, or if there is a strong family history but we haven't yet found a genetic cause for perhaps screening advice as well. Next slide, please. So this is an example of one of the tests on the test directory for inherited breast and ovarian cancer. And you can see here there's lots of different eligibility criteria that can make patients eligible for this testing, and they just have to meet one of these. And our patient here on the right, Alison, has been diagnosed with breast cancer at 37, grade 3, and has a family history of ovarian cancer as well. And we can see that she meets the first criteria there of breast cancer under the age of 40, and it's not a grade 1 cancer. If you do a couple of click-throughs, please. Yeah. So importantly, oncology can also request this test. We would accept this lady to be seen in clinic to discuss the option of genetic testing, but unfortunately our waiting list can be quite long. So there is a role here for clinical nurse specialists to perhaps, if they feel comfortable, mainstream this type of testing so results can be returned back to patients quicker in a more timely manner, maybe to help even with treatment options as well. Next slide, please. And the genes that would be on this test are BRCA1, BRCA2 and PALB2, and our lab are working hard to also add the moderate breast cancer genes CHEK2 and ATM. And it looks for sequence variants and also larger kind of exon deletions or duplications as well. Next slide. So I don't have time to go through mainstreaming for all the testing, but just to say our department has put together some e-learning to help clinicians with mainstreaming, and they're available on that website if you create an account, including breast cancer. Next slide. And as it was mentioned before, increasingly we're doing exome and genome testing, previously available through research settings, but is coming through in the NHS as well now. So R14 for acutely unwell children, perhaps on PICU and NICU, and R21 for fetal anomalies, multiple major structural abnormalities detected on scan, where finding a genetic cause may influence management as well. Next slide. So if to refer to us, you can do so by post or by email, particularly if it's urgent, like in a pregnancy. And our website also has more guidelines about when to refer if you're suspicious of an inherited cause for cancer. We also have an on-call service who's available to answer questions if you need advice, and their numbers are there. That's Monday to Friday, 9 to 5. Next slide. And yeah, more information is available on our website, and also the consent forms for mainstream testing are available on the Genomics website. Next slide. And important things to highlight in referrals is the patient's details, name, date of birth, NHS, a current telephone number is really helpful. If they have someone who has a genetic condition, their details as well, and what service they've been seen by. If we've seen them before, we give them a family number, their relative a family number. That can be really helpful to link them to a known family as well. If patients are pregnant, things like gestation, last menstrual period, estimated delivery date, and the father's details are really important as well. So this genetic testing is funded centrally. And important to consider maybe storing a DNA if a family member is quite ill as well, and so that we have that available if so testing can be available in the future if they pass away. And just remember, we don't always offer genetic testing, and if we do, it can take a long time. So to manage kind of patient expectations before referring as well. And the next few slides just have important kind of resources like the test directory, and also Health Education England have put together a lot of kind of learning modules around genomics as well for people who would like more information.
Thank you very much. No, that's okay. Thank you. Well, we should of course share the slides at the end. Just conscious of time, so I'm going to hand over to Anita, and hopefully have a bit of time for questions at the end. Okay, over to you, Anita.
Lovely, thank you. Hi everybody. If you could, Ian, go to the next slide, please. Lovely. I'm here as a clinical nurse specialist. I'm a diabetes specialist nurse, but I'm also seconded as a genetic diabetes nurse. I've been in this post for nearly 10 years now. So really, I'm just going to give you an overview of monogenic diabetes, what the scale of the problem is, how we've been managing it before we became part of the GMSA, and where we're up to now within that. So monogenic diabetes, unlike type 1 and type 2, is caused by a single mutated gene. So we see people present as if they have type 1 or type 2 diabetes initially, and then once we drill down and we understand a little bit more what's going on, we can identify what the cause is. Now, when I first started, we thought that monogenic diabetes accounted for about 1.5% of the population who had diabetes. Now that we've got more testing going on, we now know it's up to 3.5% for those that have been diagnosed with diabetes under the age of 30 years. What the aim or the highlight for us and how we came back with the genetic diabetes nurse role was 80% of people who've got monogenic diabetes were misdiagnosed with type 1 or type 2 and were misdiagnosed for many, many years. So you can see on the next part of my slide, 12 years from diabetes diagnosis to correct genetic diagnosis. And for some of our patients, it's significant changes to treatment we could have made much sooner. There have always been widespread variations in referrals. You can see from the map on here, down in the southwest where the Royal Devon and Exeter team are based, and that's who I was originally seconded through. They do all the genetic testing for monogenic diabetes, and obviously Professor Hattersley, Professor Allard and Professor Shepherd set that service up 20-something years ago now. So they look at all their patients with diabetes. I think they work on the assumption everybody's MODY until we've proved otherwise. So you can see they've got the highest pickup rate. We're getting better in the Eastern region, and the whole point of the GMSA for us with looking at monogenic diabetes is to ensure parity of pickup across the UK, because at the minute you're relying on having a genetic diabetes nurse in each region, and I'll talk about our role in a little while. But if you don't have a nurse in that region, or you don't have somebody who's covering part of a region, then your pickup was sporadic because the information wasn't getting out there. Next slide, please, Ian. And if you click on about another 2-3 times and one more. Lovely, thank you. So the diagnostic criteria, MODY is the sort of name that most people in diabetes that know monogenic diabetes for, and it's shorter than keep saying monogenic, but it's the term that is known. If we go into hospitals, we always talk about MODY. So it's early onset diabetes. We're looking at patients who've had a diagnosis of diabetes, ideally before the age of 25 years, and in 1 or 2 family members. If we've got a 2 or 3 generation history, that's perfect, but sometimes for some of our monogenic patients we don't always get that. But what we're looking for, and what we're advising clinicians when we give talks to people for who are doing clinical work, is find a family history. Have they got a parent? Have they got a child? Do they have a sibling with diabetes? Are their grandparents involved? That's a good indicator already. Are we looking at a monogenic cause? So somebody who's not insulin dependent diabetes, that doesn't mean somebody who doesn't have type 1. As we've already said in the first slide, 80% of our patients are misdiagnosed. So somebody may well be in clinic and being reviewed and being told they have type 1 and are on insulin all the time, but they don't necessarily need to be if they've got a monogenic cause of their diabetes. So this is where we would look at measuring C-peptide, which will tell us how much of the patient's own endogenous insulin they're producing. If it's in the honeymoon period, which is usually in the first 3 to 5 years of diagnosis, we may well get an elevated C-peptide, but That's one test that we'll do before genetic testing to look at ruling out different types of diabetes before we go down the route of genetic testing. We look at an autosomal dominant inheritance pattern, which is what we come back to, of diabetes in a parent or in a child, and ideally in a 2 to 3 generation family history is what we're looking at. And then what we're also looking at is, because this diabetes is caused by a single gene defect, which is altering the beta cell function, we're not looking at patients who are typical type 2s. So patients who are obese, have signs of insulin resistance, such as acantha's nigricans, very high C-peptide levels, excessively high C-peptide levels. If they look like type 2, then obviously we need to look at a bit more information around family history before we'll go further. But these are the diagnostic criteria we're looking at for. So it's a young age of diagnosis of diabetes under the age of 25, measurable C-peptide after the honeymoon period. We'll look at antibodies, and I'll talk about antibodies next, and a family history, a significant family history of diabetes, and no signs of insulin resistance, such as we've said, as obesity or acanthosis nigricans. Next slide, please, Ian. Thank you. Developed quite a few years ago now was our MODI probability calculator, which has been invaluable. We advise all clinicians to have this on their desktop or their phones when they're in clinic, because it's a really quick way of putting in your probability of a patient having monogenic diabetes. It's very simple to fill in. All you ask for is the patient's age at diagnosis, what sex they are they currently treated with insulin or oral anti-hypoglycemic agents, what was their time to treatment, did they go straight onto insulin, was there a slow build up to it, the BMI, the HbA1c, so we know what their glycemic control is, their current age now, and do they have a parent affected with diabetes. And then this will give you a percentage of what their likelihood of having a monogenic cause of the diabetes is. Now, it says on here, use with caution. At the moment, when this was first put together, this app, it was used on a predominantly Caucasian population. They're now extending it out to a South Asian population. There's work going on in the background to develop that further, and it can't be used on people who have been diagnosed with diabetes over the age of 35. That doesn't mean that people diagnosed over the age of 35 won't have a MODI cause of their diabetes. It just is one of those things you have to be aware of the calculator. It's a really good tool, but it is just a tool to help aid the diagnosis. It doesn't mean it's the only thing we rely on, because as we know, patients don't always fit into the boxes that we want them to fit into. Next slide, please, Ian. So as well as looking at the family history and the age of diagnosis, before we would go down the route of looking at genetic testing, we would look at doing some more biochemistry testing first. So I've talked about doing a C-peptide, which is measuring how much of the patient's own endogenous insulin they're producing. We then look at autoantibodies. So we would measure GAD, IA2 and zinc transporter. If your patient is antibody positive, then they're most likely a type 1. Over 80% of people with type 1 diabetes will be producing antibodies, and using all three gives us a much better indicator. We're working in our area, I think we only use islet cell antibodies, but we tend to send our testing to Exeter still for antibodies, because they'll do all three in one. So for our insulin patients, it's quite clear. We'll do C-peptide. So C-peptide is positive. They're producing enough of their own insulin, and their antibodies are negative. That would indicate they've most likely got a monogenic cause of diabetes. In non-insulin treated patients, it's a bit more difficult, because we're seeing more and more younger people developing type 2. And obviously, if you've got type 2 diabetes, you don't necessarily need insulin at the start. So you're producing insulin. So C-peptide measurement won't necessarily help from that point of view. We often will do antibodies as part of the workup to doing the genetic testing anyway, just because it's quite a useful aid. But again, you're most likely going to be antibody negative if you have type 2 as well. So when we're looking at our type 2 patients, we're then focusing on how old are they, what's their BMI, what's the family history, are there any signs of insulin resistance?
5 minutes, Anita.
Thank you. Next slide, please, Ian. This slide just shows the most common types of monogenic diabetes that we come across. So the ones that we see predominantly in clinics are HNF1 alpha, glucokinase and HNF4 alpha. We then got the HNF1 beta, which often present in renal clinics first, because often that will have renal issues before the diabetes presents. And then the others are more rare, which are our neonatal, our KCNJ11, our insulin, and our mitochondrial disease patients. They are rare, we do see them, but just as an overview, these are the ones that we most commonly see. Lovely, next slide, Ian. Oh, thank you. So this is just a summary of the most common cases that we see. When we do this talk, when I'm going to be spending a lot longer time talking about it, we do case studies, because I often find, particularly amongst nursing and midwifery staff, it's quite nice to be able to relate to a case study. So what we would do is bring up a family history and a family tree of a patient that's got glucokinase, and we discuss how it was picked up, what we went through. But just as an overview, if any of you are working out there and are in contact with people who have diabetes, glucokinase is one of the more common types of monogenic diabetes. It presents with a mild hypoglycemia, fasting blood sugar range of 5.5 to 8. But these are people who don't actually have diabetes. They're naturally run with a higher blood glucose level than the rest of the population, but it doesn't need treating. They're not at risk of developing diabetes complications any more than people who don't have diabetes. So they're a really good cohort to identify, because often they're being treated as type 2s in clinics, so we can get them off all treatment and they don't need to come in for screening anymore. They're at risk, as I say, of developing type 2 as they get older and if they put weight on as much as the rest of the population, but that's normal for them. And then just to touch on the HNF1 alpha patients and the 4 alpha patients, again, these patients, it's really rewarding when you're working with patients who have been diagnosed as type 1 and we identify 1 alpha or 4 alpha, because they can be transferred successfully from insulin to a very low dose sulfonylurea, a very extremely low dose, not a dose that we would normally use routinely in diabetes, but tiny, quarter of a size tablet, 10 milligrams, 5 milligrams is what we can get these people onto. And that's life-changing for people. If you've been on insulin for many years, to then go, actually, you don't need to be on that right now, we can manage you successfully on an oral medication. It makes significant changes. And being involved in that from a diabetes perspective, you get to know your patients, you get to know the family, and it's one of the most rewarding parts of this role. The others on there, as I say, I won't go into too much detail because we haven't got time today, but there's a lot that we can do with all of our patients, but those 3 are the ones that we see most commonly. Next slide, please, Ian. Lovely. And this slide really is just talking about the role of the genetic diabetes nurse. Now, this role has been around for over 15 years now, in fact, probably longer. Professor Shepherd and Professor Hattersley set this role up because what they identified was different clinicians in different parts of the country had different knowledge, degrees of knowledge about monogenic diabetes. So our role came about, we're working in clinics, we're working with clinicians, and what we were there really predominantly was to translate the genetic side of things into clinical practice, because as you're aware, lots of us have never been exposed to genetics, and it's a new subject for us unless we've been working in it. So we were out there, we used to go out to all the different hospitals in the region, give a talk about monogenic diabetes, and then if people are identified in clinics, we'd suggest they come back to us and we could discuss through cases. What we do now as part of the GMSA role is we have 2 monthly meetings where people can bring case studies, we can talk through them. Because I cover all of the eastern region, I also cover part of the northeast of the country as well. So from a practical perspective, it's quite nice having access to the online training. And if you go to the next slide, please, Ian, and my last slide, this just talks about monogenic diabetes. The team at the Royal Devon and Exeter have set this site up. All of the testing for monogenic diabetes goes to the lab at Exeter, and on their website they have lots of information where we signpost all of our clinicians to. And they also run a study day. They're running a 2-day study day. They've been running that twice a year for the last couple of years, aimed at upskilling and identifying people in practice. So you can always log on to there if need be, if you want more information, and there's little bite-sized chunks as well. Lovely. Thanks, Vicky.
Oh, that's great. Thank you very much. And I think that's such a great example of how a nursing role can help to implement this, genomics into a patient pathway in a really practical way. And what I think is also really great is how autonomous you are in your role, Anita. Now, I know that we are pretty much at the end of the webinar now, time-wise. Has anyone on the call got a question that they'd like to ask any of the speakers in the next couple of minutes or the next minute or so? Can either put them in the chat or raise your hand. One of the things that really has made me think today is that for future webinars, it might be helpful to have fewer speakers and longer for each speaker so that we can go into more depth. And because this is the first one, we wanted to what we'll do is send out some evaluation questionnaires to those who have attended today and find out what you would like to hear about, and we can plan for the next one. Okay, so if nobody has got any questions, we will draw to a close. Thank you to all of the speakers today for your time. Thank you to everyone who has attended. And the presentation will be shared on YouTube. If you would like to just search for East Genomics, follow us on Twitter or LinkedIn to find out more, and look out for the next webinar, which we expect will be in around 3 months' time. Okay, thank you very much, everyone.